Cardiogenic shock. Introduction. Cardiogenic shock is a life-threatening condition characterized by the heart's inability to pump sufficient blood to meet the body's metabolic demands. It is the most severe form of acute heart failure and a major cause of mortality in critically ill patients. It commonly occurs as a complication of myocardial infarction, heart failure, arrhythmias, or severe cardiac dysfunction. Definition. Cardiogenic shock is a state of inadequate tissue perfusion due to cardiac dysfunction, resulting in end-organ hypoperfusion and hypoxia. A condition in which the heart suddenly cannot pump enough blood to meet the body's needs, leading to multi-organ failure if untreated. Etiology. Acute myocardial infarction, AMI, most common cause, damage to the heart muscle reduces its ability to contract effectively. Heart failure, chronic heart disease leading to decompensated cardiac function. Cardiac tamponade, accumulation of fluid in the pericardial sac compresses the heart, restricting cardiac output. Severe arrhythmias, bradycardia, tachycardia, or fibrillation impair effective cardiac output. Valvular heart disease, conditions like aortic stenosis, mitral regurgitation, or ruptured papillary muscles can lead to cardiogenic shock. Myocarditis, inflammation of the heart muscle weakens its pumping ability. Pulmonary embolism, obstruction of pulmonary circulation increases right ventricular strain. Ventricular septal rupture, a rare complication of myocardial infarction leading to shunting of blood and reduced output. Drug overdose or toxicity, beta blockers, calcium channel blockers, or other cardiotoxic drugs can cause severe cardiac depression. Risk factors. Advanced age. History of myocardial infarction. Diabetes mellitus. Hypertension. Chronic kidney disease. Severe left ventricular dysfunction. Previous heart surgeries. Sepsis or severe infections. Pathophysiology. Primary cardiac dysfunction, example myocardial infarction, arrhythmia, valvular disease. Down arrow. Decreased myocardial contractility, reduced ejection fraction and stroke volume. Down arrow. Decreased cardiac output and hypoperfusion, inadequate blood supply to organs. Down arrow. Activation of compensatory mechanisms, sympathetic nervous system activation, vasoconstriction, and renin-angiotensin system activation. Down arrow. Increased myocardial oxygen demand and worsening ischemia. Down arrow. Tissue hypoxia and lactic acidosis, due to anaerobic metabolism. Down arrow. End organ dysfunction and multi-organ failure, renal failure, hepatic dysfunction, neurological impairment. Down arrow. Death if untreated. Clinical manifestations. Cardiovascular symptoms. Hypotension, SBP 90 mmHg for more than 30 minutes. Weak, rapid pulse. Cold, clammy skin. Chest pain, if due to myocardial infarction. Respiratory symptoms. Dyspnea. Pulmonary edema, crackles on auscultation. Cyanosis. Neurological symptoms. Confusion. Decreased level of consciousness. Renal symptoms. Oliguria or anuria, low urine output. Diagnostic evaluation. History taking. Recent myocardial infarction or cardiac event. Presence of cardiovascular risk factors. Symptoms of chest pain, dyspnea, or dizziness. Physical examination. Low blood pressure. Tachycardia or arrhythmias. Cool, mottled skin. Pulmonary crackles. Jugular venous distension, JVD. Specific tests and procedures. Electrocardiography, ECG, detects ischemia, infarction, or arrhythmias. Echocardiography, evaluates left ventricular function, ejection fraction, and structural abnormalities. Cardiac biomarkers, troponin, CKMB, BNP, Assess myocardial damage and heart failure status. Chest X-ray identifies pulmonary congestion or cardiomegaly. Hemodynamic monitoring, Swan-Ganz catheter, measures cardiac output, pulmonary artery pressures, and systemic vascular resistance. Blood gas analysis determines oxygenation and metabolic acidosis, lactic acidosis. Medical management. Hemodynamic stabilization. Oxygen therapy to improve oxygen delivery. Intravenous fluids, carefully administered to avoid fluid overload. Vasopressors, norepinephrine, dopamine, to increase blood pressure. Inotropic agents, dobutamine, milrinone, to enhance cardiac contractility. Revascularization, for UMI. Percutaneous coronary intervention, PCI, or thrombolytic therapy. Coronary artery bypass grafting, CABG, for severe cases. Mechanical circulatory support. Intra-aortic balloon pump, IABP, to improve coronary perfusion. Left ventricular assist device, LVAD, for end-stage heart failure. Extracorporeal membrane oxygenation, ECMO, in severe cases. Pharmacological therapy. Diuretics, furosemide, for pulmonary edema. Antiplatelets, aspirin, clopidogrel, for coronary protection. Beta blockers, used cautiously, to reduce myocardial workload. Treat underlying cause. Arrhythmia management, cardioversion for tachyarrhythmias, pacing for bradyarrhythmias. Valve surgery if valvular dysfunction is the cause. Surgical management. Coronary artery bypass grafting, CABG, for severe coronary artery disease. Valve replacement for valvular dysfunction. Ventricular assist device implantation for end-stage heart failure. Heart transplantation in refractory cases. Nursing management. Monitor vital signs and hemodynamics, regularly check blood pressure, heart rate, oxygen saturation, and urine output. Ensure oxygenation, administer supplemental oxygen and monitor respiratory status. Administer medications as prescribed, vasopressors, inotropes, diuretics, and anticoagulants as per physician's orders. Prevent complications, monitor for arrhythmias, renal dysfunction, and worsening shock. Psychological support, provide emotional support to the patient and family members. Education and discharge planning, educate on lifestyle modifications, medication adherence, and early signs of heart failure. Complications. Multi-organ failure, renal, hepatic, cerebral dysfunction. Pulmonary edema. Arrhythmias and cardiac arrest. Ischemic limb due to vasopressor therapy. Stroke due to embolization. Death if untreated. Prevention. Early detection and management of myocardial infarction. Control of hypertension, diabetes, and cholesterol. Smoking cessation and lifestyle modifications. Regular cardiac check UPS for individuals at risk. Immediate treatment of arrhythmias and heart failure. Conclusion. Cardiogenic shock is a medical emergency with high mortality if untreated. Rapid diagnosis and aggressive management are crucial to improving survival rates. Advances in pharmacologic and mechanical support have improved patient outcomes, but prevention through early risk factor management remains key.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.